Hi, I'm Dan Cook with Bone Zone, and welcome to another edition of Ortho Innovators, sponsored by Metalcraft. On this episode, I'm excited to be joined by Dr. Louis Circle, who founded Sign Fracture Care to create equity in treating fractures throughout the world. I'm also joined by Terry Smith, Sign's engineering manager, who will share some insights into the way the organization designs trauma implants and instruments. Dr. Circle, let me start with you. You served as an orthopedic surgeon in the U.S. Army during the Vietnam War. How did that experience inspire you and inform your decision to start the sign program?
That experience was life-changing for me. It it was the start of Sign because I knew that these people that were getting shot weren't getting cared for, and I got to meet others as we went along. But it was a life-changing experience for me.
And it was really the citizens, wasn't it, that
Yes,
weren't getting the care. The army soldiers had care, but it was really
that's
the
what.
citizens.
Yeah,
Yeah.
U.S. Army had care, but Vietnamese Army did.
So when you came back from war, what were the first steps then of establishing the program as we know it today? What was the infancy like, and tell me about just the basics of the launch.
Well, when I came back, I realized that a lot of people in the world were not getting good care, and I wanted to help provide that. And I did so, and I first of all wanted to work for organizations, but then I decided that I wanted to do what needed to be done myself. And a group of very interested philanthropic people gathered around and helped. And we established quite a center for orthopedics in Vietnam and then in Indonesia.
Yeah. And how does the system work today? Talk about the just walk me through how the sign system works, how you train surgeons, how you get the supply to needed areas, how you recognize or identify needed areas.
Well, the system works today because of people like Terry, who look into what they need and try to supply it. And this is a changing thing. Do you want to?
Yeah, I can. Yeah, I can answer some more of that. And so, really, Dan, a lot of this goes back to our start 26 years ago. Dr. Zirkle and our CEO Gene Dillner, they traveled quite a bit, several times a year, and they would go visit hospitals, and started to do training with our implant system. And so, the unique part of our intramedullary nail is we can use it in hospitals that do not have real-time X-ray. And so that kind of grassroots effort led to a lot of hospitals communicating with each other, realizing that we had a an intramedullary nail system and a surgical training that they could use in their hospitals. And so it was really a grassroots effort. And now, 26 years later, we have dozens of mentor surgeons throughout the world that do the bulk of the training within what we call our Sign network of hospitals. And then once a year, we do an annual conference where we have somewhere between 75 and 100 and say 20 surgeons throughout the world that'll come to our facility in Richland, Washington. And it's really a lot of peer-to-peer learning and training. They're teaching each other. Dr. Zirkle's giving lectures. We have what's called a bioskills lab where they get hands-on training with cadaveric specimens. And sometimes it's U.S. surgeons that are the trainers and leaders, and sometimes it's our mentors that have been with Sign for years and that do that training. And then we have an application process for hospitals that want to work with us, that they will apply to become a Sign hospital, and then we have an approval step that goes through that. And then once they become one of our hospitals, there's a couple of ways that they get trained. Sometimes, like I said, it'll be a mentor, is the majority of the time. And then they will start doing surgery, and then they report cases back to us. So we have a surgical database, and for them to participate with us long term, we ask them to provide us information about the surgeries that they did and the implants that they used. And so they have some skin in the game that we're able to with us. Yeah, so that's kind of the womb to tomb side of that. Did I cover it all right?
Good.
Yeah, all right.
That's-
Okay.
Good
Oh, that's
job.
great.
That's why we're successful. We have people like Terry.
Understood. No, that's great. So you talked about the lack of imaging, perhaps, in some of these hospitals around the world. What are some of the other challenges in treating fractures, in these settings that you may, talk about surgeon education? What are some of the barriers that you have to overcome as a program to get this program up and running?
So, a lot of the hospitals and the surgeons, depending on what country they're in and what area, they may or may not have consistent power throughout the day. We have great stories. I don't know if they're great stories. We have lots of stories about surgeons that use headlamps that will patients have to bring their own fuel to run the generators so that they can have surgery. To patients have to buy their own antibiotics. And so we don't, as an organization, we have donations of headlamps, but we don't provide the antibiotics and some of the fuel, obviously. But what we do also see is it can be anywhere from, we provide instruments that can be resharpened, and we provide the sharpeners so that they can maintain their own equipment. We have hospitals that don't have surgical drills that can be sterilized in surgery. And we see images and pictures where they may have construction drills in surgery. And so in our mind, we look at that and like, oh, how's that sterilized? And so what that led to us designing what we call a drill cover. So the drill will go into essentially a cloth bag that can be cleaned and sterilized multiple times. And then we have stainless steel drill chucks that will be used on the outside. And then so now a surgeon has a sterile barrier to use with his common construction drill. And so we just try to find those areas where the surgeons, they have a lack of something and where we can fill the niche. Yeah.
Great. And that dovetails into, wanted to ask you about your implants and instruments and the design of those. Talk about what goes into that and how that makes them applicable in areas across the world by various skilled surgeons.
Sure. Yeah. A lot, like I said, a lot of this goes back to 26 years ago with Dr. Zirkle and traveling and working with the surgeons overseas and understanding their constraints. And so when he saw that the surgeons could not use donated implants from the US because they required the use of X-ray during surgery, then we developed our intramedullary nail system. And so it's really, from a product development engineering perspective, it's a lot of fun because we have just direct access to surgeons. So we have a lot of the voice of the customer that we get to hear. And so it's in that process of understanding where they may have a problem and how we can solve it. And so it's a lot like product development that's done here in the US, but they have some unique challenges. How our devices need to be re-sterilized and used multiple times. You'll see in the US, a lot of the medical device companies are moving to single-use devices, so they're used once and thrown away. That's not a sustainable model for the hospitals that we support. And so it's just working through and understanding the constraints that they have in their particular setting. So all of our equipment can be used hand powered. So one of the steps in the surgery or prepping for surgery is the surgeon will ream the center of a bone canal out. And so we have hand reamers that are just hand powered. And like I said, they can be resharpened. And so it's just really, Dan, it's really going back and taking a different look at their constraints that they have and developing items for that.
Yeah. You talked about having the hospitals report back to you in terms of the cases they perform. How do you use that data to inform maybe, how the program is run or how devices are used and distributed? Just tell me about that, the use of that data.
Well, we read it and try to correlate it first to
Mhm.
see what just one case or is this 20 cases
Mhm.
saying the same thing. So that's a big help that way. And then also we look very carefully at each case, the results. What went right, what went wrong, and we try to replicate that in our revisions, in our new instruments.
And Dr. Zirkle brought up a great point. Each of the cases that are reported are reviewed, and then there's also mentoring that can go on with that, and that's the second part of our training and education that I skipped over earlier. And Dr. Zirkle has looked at probably 90 to 95% of those cases. So right now there's about 250,000 cases in the surgical database, and he's provided feedback to the bulk of those a bulk of those surgeons. And so there's a lot of mentoring and relationship building that Dr. Zirkle has done over the years through the database and the feedback. And then, and as he noted, we will, as the engineering team, we look at the different cases, and we'll do studies to look at how effective our implants are, how effective the surgery, and we also can see how effective our training is, and then maybe make adjustments with that.
Using that perspective, how has your care of fractures evolved over the years? It must have been, looking back to where you began and where you are now, it must be so different. Just can you share a little bit of insight into that process?
Well, we have good good instruments now that are more applicable. And for example, we have a way to take skin grafts and make lines down so it can be expanded. This is a big deal because a lot of the open fractures need to be covered to prevent infection. The other thing that we have and we do is the fact that, well, the drill cover is an example, but another example is our reamers. Our reamers are used for many, you might say, just to make the hole bigger in the canal, but they are used to give us a tight fit for our implants. And it's given us the opportunity to use the fin nail. The fin nail does not have screws going through the top. It has a fin. And the fin gives us as good as a stability as a nail with screws. We're in this process of looking at thin versus standard nails at this point. And it's working very well. The thin nail also started by luck. I remember I was in Bangladesh and I had a plane to catch, but we had to finish the case, and we had these reamers, and the reamer got hung up, and so I
Like
thought,
stuck in the patient's bone canal. Yeah.
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 So I realized that this is not good, and so we worked on this and made what we call the fin nail. We are now studying the results of using fin nail versus our standard nails, which has screws going through, and we found that the fin nail provides equal stability to the standard nail. So we might be making some changes to more fin nail. We have to see.
And yeah, and I think at the beginning, the goal was to treat tibia fractures, right? That was kind of the real start if we go clear back to the beginning. And then through innovations of our surgeons working with Dr. Zirkle, that particular first nail they started to use in the femur, and then like Dr. Zirkle said, we learned from getting that he learned from getting that reamer stuck in the bone canal that there's another nail configuration that we could come up with that could be used, and we created the fin nail, as you said. So now our nails, they can be used on the left-hand side of the body or the right-hand side. They can be used in the tibia, in the femur, either up through the knee or down through the top of the hip, or in the humerus. And so you'll see a lot of U.S. medical device companies, they'll have a unique nail for each one of those approaches, where we have, a given nail, if it's the right size, could be used in any of those three bones. So it's very universal. That's the other part, is what we've done is, so it helps keep inventory costs down. It's signed, but also helps minimize the cost of inventory management in the hospitals. Yeah.
Understood. You talked about mentorship and tracking cases. Is there anything else? I'm assuming that would, impact a long-standing relationship with a hospital. Can you share perhaps some of the success stories of longevity? You've been working with a hospital for how many years, and just some of the success you've realized in specific facilities?
Well, first, to talk about reporting, we now have a group of surgeons who look at the reports and offer their advice. I think the more we can incorporate the surgeons into sign administration and reporting, the more they learn and the more we learn from them. And one of the surgeons told me, a particularly good surgeon from Pakistan, told me that he really learned a lot from reading the database.
I think there's one hospital that I want to, and one country in particular that I'll highlight. I was fortunate to go to Ethiopia last year. And when we were in Ethiopia, they had, sorry, I'm going to get emotional because I don't know why, but I will. But they had a orthopedic trauma association. So, and I think it was probably back in 2008, 2009. I think it was when you first went to Black Lion Hospital in that period, or early 2000s, and visited a surgeon there, Dr. Baruch Washimo, and he was the head of Black Lion, is a teaching hospital. And about the same time, there's another surgeon from the U.S. who went to Ethiopia at a hospital called Soto Christian, and his name was Dwayne Anderson. And he started a orthopedic residency program there. And so eventually those two hospital administrators and Dr. Zirkle and Dr. Anderson met, and they realized that now they had somebody in country teaching surgeons how to be orthopedic surgeons. Sign and Dr. Zirkle brought the implants that could be used. And so now Ethiopia has a burgeoning orthopedic training program. They have a couple orthopedic trauma fellowships. We currently support 49 hospitals in Ethiopia, and last year they honored at this Ethiopian trauma conference. They honored Dr. Anderson and Dr. Zirkle for being the founders of orthopedic surgery in Ethiopia. So I think that's one of a great success story of Sign and the efforts of Dr. Zirkle. Yeah.
Awesome. Thanks for sharing that. That's great.
Yeah.
Moving forward, how can, orthopedic professionals, you say you work with surgeons, how can surgeons continue to support your program? How can industry continue to support your program? Talk about what your needs are, both, from a resource standpoint and a knowledge standpoint.
We have a lot of different companies that support us in different ways. Whether it's through discounts on software, whether it's working with us in our supply chain, and they obviously companies have to cover their costs, but they will, a lot of times we see discounts and we know that we're probably getting discounts relative to on raw materials, or they control pricing for us to make sure that we're, because they understand the mission. They understand that we're donating our implants for free to the injured poor. And so they work with us in various ways. Maybe it's also in co-marketing. So those are probably the biggest ways. We see donations of some implants. We have to kind of be careful that those implants are usable overseas.
Sure.
Back to like but if they're bone plates, bone screws, things that are used in surgery without the use of an X-ray, a C-arm, then those donations we usually accept, and then those will go out to different hospitals. When it comes to, say, surgeons wanting to help, it can be anywhere from, if they want to sponsor a program and open, which means that they would fund an instrument set and a set of nails to go to a new hospital. We do anywhere from that to, if they have they travel overseas and they're working in a hospital overseas and they want to. Maybe they're a courier and they're taking implants to that hospital, or maybe they have a specialty that they want to share with the hospital. So we see all of that. Yeah.
That's great. Along those lines, we're excited to have you involved in OMTEC this year, which will be June 17th and 19th in Chicago. You'll be exhibiting there, and we're donating a portion of some of the registration cost to your program. We're excited about that. Tell us about your involvement with the conference, what you're looking forward to, and what attendees can learn by stopping by your booth. Sure.
Well, yeah, no, we're actually very thankful that we have the opportunity to come and be at OMTEC and to be able to show the attendees there what we do at Sign. We will have a table. We'll have a bunch of our instruments. We can talk people through what surgery looks like in the steps. We will certainly be able to share about the impact that Sign has had over the last 26 years through the various hospitals we've worked at in the countries that we're in. So yeah, it'll be great. People can come by and understand where they might be able to contribute unique talents or gifts to us. So,
well, looking forward to it on our end as well. And thank you both for joining me today. It was really a pleasure to talk to you. And thanks again to Metalcraft for sponsoring this episode.